Abnormal gait. Gait. Series of rhythmical alternating movements of trunk and limbs which result in the forward progression of the center of gravity. The walking pattern or style may differ from individual to individual. It depends on the age, sex, mood of an individual and may be due to some diseases. First, hemiplegic gait. The gait is typically seen in patients with spastic hemiparesis. The patient holds the arm tightly to the side flexed and does not swing it as in normal pattern. With each step, patient tilts the pelvis upward, that is hip hike, on the involved side to aid clearing of the ground. Also, he may swing the entire extremity around in a semicircle from hip. The stance phase is shortened because of the weakness. The swing phase is also shortened because of spasticity. The patient is able to turn towards the paralyzed side more easily than normal side. In this following video, we can see that affected side arm swing is absent, shoulder are depressed, adducted and internally rotated, elbow are flexed, wrist and fingers are flexed. On affected side, hip hiking and circumduction is present. There is reduced knee flexion, ankle is in plantar flexion and inversion. Second, Parkinsonian gait. This gait is also known as fascinating gait. Slowed walking is a hallmark characteristic of PD, primarily caused by rigidity, bradykinesia and poor postural control. Axial rigidity contributes to an abnormal stooped posture with head and trunk forward and knee flexed. The gait is slow, stiff and shuffling. The patient walks with small and tiny steps due to narrow base of support and balance problem. In this video, the components seen are stoop posture, arm swing reduced, small step with narrow base of support, knee flexion reduced, heel strike and toe off absent, swing face reduced, patient freezes during walking. Third, Caesar's gait. The gait pattern occurs in patients who have severe spasticity of the legs, result of spastic paralysis of the hip abductor muscles which causes the knee to be drawn together so that the leg can be swung forward only with great effort. Generally occurs in the patients with congenital spastic diplegia, CP, and in chronic myopathies. The patient walks on abnormally narrow base with a stiff shuffling gait dragging both the legs. There may be marked compensatory sway of trunk away from the side of advancing leg. In this video, the components are knees and thighs crossing while walking, excessive adduction of the leg in swing phase, adduction and internal rotation of the hip, excessive flexion of the knee and plantar flexion of ankle. Fourth, waddling gait. The gait is seen when there is weakness of hip girdle muscles. Waddling gait is particularly common in muscle dystrophy and other myopathies. When the weakness is bilateral, there is an exaggerated pelvis swing that results in hip girdle gait. Trendelenburg sign is an abnormal drop of the pelvis on the side of the swing leg due to hip abductor weakness. The patient walks with a broad base with an exaggerated rotation of pelvis, rolling hips from side to side with every step to shift the weight of the body. In this video, the components seen are patient walks with wide base of support, trunk side flexion while walking, opposite side pelvis drop while walking. Fifth, hand to knee gait. When quadriceps are weak, there is weakness of knee extension and patient can only accept weight on affected extremity by bracing knee with his hand. Patient with polio and femoral neuropathy are having this type of gait pattern. In this video, the components seen are trunk bending on affected side, hip hike on unaffected side. Patient with weak quadriceps stabilizes his knee by leaning forward on the affected side and pressing over lower thigh by his ipsilateral hand during the stance phase. 6th, antalgic gait. Stance phase of affected leg is shorter. Swing phase of uninvolved leg is decreased. Patient shifts the body weight over affected leg, result from any lower limb injury. The components seen are right side arm swing reduced, weight bearing on affected side, stance and swing phase reduced in lower extremity, and heel strike is reduced. Seventh, steppage gait. This gait pattern is typically seen in patients with foot drop. Patient excessively bends his hip and knee while walking. Patient lifts his leg high off the floor to clear the ground and avoid dragging. While placing the foot on the ground, forefoot come into contact first, followed by heel, and this will create a tapping sound with every step patient is walking with this gait pattern. Weak and paralyzed dorsiflexor muscles result in foot drop. The components seen in this video are raising the thigh while walking, increase knee flexion while walking, dragging the foot on the floor, slapping the foot down with each step, and plantar flexion of ankle joint. 8. Ataxic gait. Ataxia is typically defined as the presence of abnormal uncoordinated movements. An unsteady staggering gait is described as ataxic gait. Ataxic gait can be caused by abnormalities within the brain, spinal cord, and peripheral nervous system. Ataxic gait is often characterized by the difficulty in the straight line, poor balance, and widened base of support. These symptoms often resemble gait seen under the influence of alcohol. Also, there is lack of proper coordination, unsteady gait with the potential to stumble and fall. Frequent falling episodes are present. Lack of muscle coordination in the leg is there, and there are ambulation difficulties. 9th, equinus gait, seen in club foot. Forefoot strike to initiate gait cycle, weight bearing on affected limb is decreased and limp is present.